Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Hi, everyone. Welcome back to Talk Dizzy to Me. I'm Dr. Abby Ross, vestibular physical therapist, neuroclinical specialist, joined as always by Dr. Danielle Tolman, also a vestibular therapist. And today I'm going to give her Instagram handle first because you probably know her from Instagram if you're a physical therapist. JJ Mowder PT on Instagram. We have JJ Mowder-Tinney today on Talk Dizzy to Me. She's a fellow physical therapist. Super inspiring to all of us other physical therapists with her creativity and how she engages with patients. JJ, welcome to the show.
Oh, well, thanks, Abby. Thanks, Danny. It was really nice of you guys to ask me. I have to say I was really surprised because I'm like, yeah, I don't do vestibular. Are you sure you really want me to come on the show? I mean, I was very honored to be asked, but yeah, so I was like, I'll do whatever. So whatever you guys direct me to, I'm happy to talk about it because there's one thing I do well is talk.
That's why you're here. Part of the reason to our audience why we had her on the show was because we wanted you to all see the creativity that can happen in physical therapy and also patient specific, right? What works for one patient might not work for another patient, and you have to get creative with it. And if you've seen her Instagram, you know this is the case in her education. So JJ, can you tell our audience a little bit about your physical therapy path? Where did you start? Where are you at now?
Wow. So I really like to say, or I like to tell everybody that I grew up in my mom's physical therapy clinic. She was a PT, first woman in Colorado to start a private practice. Wow. And so I literally grew up in her clinic. And then I was always asking, when can I work? When can I work? And she's like, when you're tall enough to get the hot packs out of the machine, then you can work during the summer. And I never babysat. Hence my husband and I don't have kids. I never babysat growing up. I worked 12-hour days in the summer all day long at her clinic, ultrasounding. Yes, I was 12 and that's frowned upon now. But back then, not so bad. I'd make hot packs. I'd take people in the pool because she had a pool back in the 80s before pools were cool because my mom was ahead of her time. So she passed last year, but I have to give a big shout out to her because she's why I could see that there's never any limitations. Like, sure, it was just more of, sure, I'll try that. Sure, I'll try that. Sure, I'll try that. So when I first started, getting my PT degree and then moving up and working in the hospital, University of Rochester, like a 750 bed hospital, I honestly thought I would be a therapist forever. Like, just like my mom. I mean, she literally practiced until they bulldozed her clinic because she had it for over 30 years, and she was in her late 60s when she finally retired kicking and screaming. And I just never thought I'd do anything but be a clinician. And people just kept saying, wow, you're a good speaker. Oh, wow, you talk. And the big thing is I'm a hardcore, like many of us here, I just want to learn. Like, I just wanted to learn. So I take this course and I took that course. And I started off in the wound care in wounds. And I was like, I don't know how to do anything but debris and orange. And I don't think that's going to take me very far. So, I took multiple courses. I became a certified wound specialist. I, just kept, and that took me into seating and positioning, which took me into spinal cord, one of my dear loves, which then got me into rehab and in acute inpatient rehab, which is a setting I love dearly. And so to me, it was just constantly, and I don't get certifications just to say I have certificate. I just want to learn stuff. And it's never ending. And neuro rehab, it's hot. It's hot. I mean, I remember 15 years ago, vestibular wasn't a real thing. I mean, we weren't as there wasn't so much to learn about it. Like, we didn't know. Yeah. And I find it fascinating how we continue to grow and learn. And I feel like I take way too much credit. Your intro was so nice. It's the therapists out there that, provide me so many different treatment ideas. But I did end up going into teaching and working at a pro bono clinic, and I'm in academia, but I spend my weekends traveling and lecturing. And it came down to constantly searching to learn new stuff and always saying, sure, I've never done that before, but I'll try it. That's how Instagram started. I mean, for those of you who follow me, like, shout out to you, but like, I don't know what I'm doing, which is, I think, pretty obvious. It's just, someone said, you should do social media so we can see some of the videos you show us in your lectures. And I was like, and I have such amazing contacts with people and, all the patients that I still consult with who want to do videos for me, who I'm just so grateful, because I'm just like, you're helping so many therapists. We're just trying something out. And so, like, I just was like, okay, sure. Like, I don't know what I'm doing. And I had a friend's daughter help me get started. And then I was just like, okay, I'm not going to make anything fancy. Like, that's not going to happen. So let's just start posting stuff.
Well,
And
I think that's what makes it so much fun to watch and so interesting, is that it's not overproduced, that it's like something that you just do right then and there, that you're in the moment doing, and you're just giving us ideas, and you're putting things in front of us that we're like, oh, why didn't I think of that? Or, oh, that's a great idea. Like, I can watch some of your videos and immediately think of a patient I'd love to do that with, or there's somebody that would be perfect to try that with, which makes it so relatable and so much fun. But one thing that I love, which I didn't know, was how early you were exposed to physical therapy and in the works of that, and seeing, working with patients. I'm the same way, where I do all this Con Ed and I continuously chase the next certification that I feel like is going to help my patients, and I get into these new interests. But you got to start at such an early age. No wonder you've done so much in such a short amount of time, because you started like 12 years earlier than all of us when it comes to getting out of grad school. Like, I was just having a conversation this morning with another physical therapist, how I wish I could go back to PT school now, knowing what I know, and enjoy learning, because there's so much to this field. There's so much depth, and there's so much that we can do with patients. So I think that that's amazing. And probably that big foundation that your mom gave you growing up in her clinic really is kind of driving you to where you are now, constantly chasing all of this amazing information, constant learning, and then sharing that with everybody is such a gift. We are benefiting from that immensely.
It's so much fun. I mean, I remember my mom, I was like, I don't want to be a part of the association. Like, it costs too much money. And my mom's like, you're going to be part of the association. You're a professional. I was like, oh, okay, I'm done. And then, but I remember I was like probably 6 or 7, and she'd take me to conferences with her. And she was like the program committee person. And so I'd be stuffing the bags, so it's kind of like just who I am, and I think going back to, like, you said something that really resonated with me, because I say it all the time. It's like, where did that come from? Like, I wish I would have thought of that. Like, there's so many times where I'm like, this is a good idea. And I feel really smart for like 5 minutes. And then, like, I tell someone about it, and they're like, well, why don't you just do this and then switch it around here? And I'm like, oh my gosh. Like, to me, that's the most exciting thing, is to be like, oh, like, well, if you want to be logical about it, is how I always joke to them, because I'm like, what? And then, so I just am so grateful and enjoy immensely the therapists that I get to meet all over the United States from doing courses, because, and then when they're nice enough to come up and go, oh, Jay, I just wanted to show you this. I'm like, oh my gosh, like, that is the coolest thing. And I know it's not something like, when I share those ideas, it's purely like my motivation for my channel, when people are like, oh, you probably, you need to focus on this. And I was like, I don't really need to do anything. I figure, it's just, my goal is to, like, that one day where you're like, oh my gosh, like, it's been a long day, right, Abby? It's been a long day. And I have someone who I want to help so much. That's when we start to feel bad, when we have people, they're complicated, because we're talking the brain. Our patients are complicated, and we want to help them so much. And we're so hard on ourselves, expecting us to be able to find an answer. And there just isn't one answer. And so sometimes you just need a little something, like, oh, I don't know, let me just try that. And a lot of times it probably doesn't work. And that's the thing, is I think, and I obviously feel animated about this, but I think that if we could just be nicer to ourselves, that it is telling us a lot when something we try doesn't work. Mm-hmm. Now, what's a problem is if we keep doing it over and over and over, and we kind of say, well, they had a stroke, or they have this, and so that's why they can't do it. We don't do that intentionally by any means. Don't get me wrong, because I've done everything. I say, maybe we shouldn't do that. Oh, I've done it. But It's more about recognizing, okay, this isn't working and I have so many other options. If it's a motor learning strategy, enhanced expectancy, like you can do it. Well, some people don't respond well to rah-rah. And if they don't respond well to rah-rah, then you go knowledge of results and you time what they're doing and you count the repetitions and you show it. Look how many more you did this time. You try a different strategy. And so, giving them more choices, but make it simple. Well, my patient can't. That's where I think I want to support therapists and saying, well, I'm in acute care, like my patients can't do that. Well, not everyone can, but just can we push them a little harder? Could we have them throw the pillow instead of just sit up? Could we, so more ideas you have, then the less helpless I think as a therapist you can feel. It's because when you sit there and all of a sudden you're like, I don't know what to do. So that's kind of that's my kind of goal. I don't know if I'm accomplishing it, but that's kind of where I'm going with that. I don't know how to organize it better or whatever, but I do think being nicer to yourself needs to be like the heading on everybody's clipboard in the morning, is just take a deep breath and be nicer to yourself and listen to your patient, right?
Yes, absolutely. And even though maybe this is not going to be so much of a vestibular specific, vestibular falls under neuro. And I'm so glad you brought this up because I think it's an important message for patients to hear too. Sometimes in neuro rehab or under neuro rehab and vestibular rehab, it is trial and error. We are going to give you our best go. And if we don't see that it's working out, we're going to go to option number 2. There's a quote that I love. I probably won't say it correctly, but it's basically like, you don't fail until you quit. And it's the same as a therapist. It's also the same as a patient. You're not going to fail until you quit because you're learning with every quote unquote failure, with everything that's not quite working the way you want it to. I think that's such a good message for therapists and patients alike, because in neuro rehab and in vestibular rehab, these can be long courses of care.
And I think that, just because I love what you said, and you said it different, but it's like go in with gusto, right? Like you try it, like you really try and get that movement, try it harder, and then make your adjustment. And I think when you have that opportunity with a patient, like I just remember thinking when I first started, it didn't last long. It was like my first year out, I was thinking, I have to look like I know what I'm talking about. And I have to tell them what to do. And I have to direct it. And I have to be something that I wasn't, if you can't tell. So I'm more of a humor person, and trying to get people to laugh is usually my, just my stick is direction that I go. But I think that once I got over that, I had to tell them what to do and started asking them for help. Like in acute inpatient rehab, sometimes you get someone who is in a holding pattern. And I would go up to my patients with spinal cord injuries and I would say, teach me everything you know, like teach me your favorite tricks so that I can pass it on to someone else. Or coming back from a course, especially in the pro bono clinic, like I come back and I rub my hands together and I give them a look and they're like, oh, you went to a course, or, oh, you read an article. And I was like, I did. And I said, can I try these 3 things out on you? And you tell me what you think, give me feedback. And I know we don't have a lot of time. You all, since I'm mostly in academics, but y'all don't have a lot of time to do that. But every once in a while you do. And when a patient can help us, when we include them in part of getting their feedback and asking them what their thoughts were on this one or this one, which one did you like better? Like I'm trying to figure out for other people, like what might work. And it's amazing how no one ever asks them for help. And so, incorporating that piece has made a lot more fun for me. Like, because, I do that all the time when I'm interacting, when I'm consulting online now, when I do Zooms online. It's amazing, how you can build such a rapport online in a very short period of time. I'm usually looking at someone in an hour and trying to get the 2 biggest heavy hitters and go all in and see where we could go from there. But I think that piece of coming back and forth and asking them is just really fun.
Well, I think that it's hugely important, even if we want to specifically get into vestibular, because yes, we have our foundational exercises like gaze stability and, everything in the realm of habituation and adaptation. However, every single patient presents differently. Everyone's going to react differently. And something I want to hit on that Abby had mentioned about these failures where I try to, one, engage patients, make them feel like they're part of this journey and that they're going to help me figure this out with them, right? Because everybody's unique, whether it's they want to be able to get back to hiking in the woods with their dog and be able to look up into the trees and not get dizzy. Or I had a 70-something-year-old go out to California to go rock climbing and he wanted to be able to look up without getting dizzy. So like there's different goals, but when it comes to finding stuff of what works and what doesn't work, I try to say, we didn't fail at it. It is something that is just moving in the wrong direction. Like, okay, now we've checked off the box. We know that's something that doesn't need to be worked on, or know that something isn't working for what we're trying to achieve. What else do we have to do to get there? What are you doing at home to replicate symptoms? What has been difficult at home, and how have you been trying to combat that? And how do you compensate for that? And using that information from the patient to build up your exercises, I think is widely so much more successful in terms of seeing improvement in the clinic, but also getting the carryover back in the home for them to be consistent with their exercises, right? Staring at a Post-it note and turning your head back and forth is not the most appealing thing in the world, but or exciting and fun thing to do. But if you can find a way to incorporate their dog or have them, if they like to watch the news, read the ticker along the bottom to help decrease sensitivity to visual conflict, there's beauty in that gets the patient to buy into it. So I think that you're absolutely right. Like just keeping things engaged with the patient, having them contribute to your exercises and how you're going to work with them. It might be more difficult on the clinician side of things who want, this regimented, things of exercise make it easier to document. I think it's so much more rewarding on the patient end of things to take the time, individualize every single person's plan of care in order to get them to buy in and see better success quicker. So I think that just having that patient buy-in, having that feedback from the patient is widely important for even specifically vestibular patients, not to mention a lot of the neuro components that get pulled into that as well.
And I just love what you said, because this ties to, it's back to their quality of life. It's back to their life. This is about them. This isn't about now. And I think regimented sometimes comes in where we think that's how we're supposed to do it. We're supposed to do this, and then we go to step 2, and then we go to step 3. And when we're learning, that's all good, and you need that foundation. But I think that once you start to break away to what does a day look like to you? What does, do a little video of your house just so I can kind of see your layout. So even when you sprinkle in like little pieces that you're paying attention, because you don't always have tons of time, but once you see their house and you sat and looked at that video briefly, we know as we're taking a walk, as we're walking our dog, we'll all of a sudden have a thought. Or it's always about airports for me, since I travel every weekend. And so, I'm just like, how could you, if you had any kind of dizziness, how could you survive the Charlotte airport? I'm just not sure that it's possible, because start stops and then all the visual distractions and then walking on stepping, moving escalators, like there's just pulling something at the same time, all and being stressed that you're going to miss your flight. Like all those things. It's just, there's so much out there. So really, the more we find out, I just think we can do whatever. We could get as fancy or not fancy, just go hardcore in our clinic if you're an outpatient. But if there's not something that they can carry over at home to help improve that, then it's hard. And we don't have the answers. Don't get me wrong. I'm just saying that the patient can give us the answers when we listen to them. Mm-hmm. And usually it's a complaint, like head for those complaints. When someone starts complaining about something, sometimes we back away and just like walk backwards slowly because we don't want to hear. But let's go dive deep into that complaint. Don't put pressure on yourself to have to figure out the solution, because once we're like, oh, I don't want to listen because I'm not going to be able to figure this out. I've learned better with students. They ask a question like, whoa, Nellie, that was a really good question. Like, instead of leaning back and just saying, okay, let's move on. And now I lean in and go, you know what? I don't know, but let's search for it. I think that if you lean in without the expectation that you are going to solve that problem, but that you're going to take it and incorporate it into some kind of activity for home, I think it's just, I don't know. I think that's helpful.
Absolutely. And all of this conversation that we've had so far, I feel like leads into empowering the patient and what positive impact that can have on a patient's outcomes. So you're engaging the patient, you're asking them questions, what's meaningful to the patient, asking them for feedback about what works, what doesn't work. All of these things that you're doing are empowering them. Are there any other tips or tricks you have for getting patient buy-in, building rapport, making a patient feel empowered in their journeys?
Well, I think great question. I think that we covered what I usually go with, and that's, and sometimes it's an interaction between their loved one, and there's a little bicker going on, and I'm hearing that, oh no, they have to do it this way, or they need that chair brought down, and I'm like, why do they need that chair brought down? Well, they won't sit in the rolling spinning chair, and so now I have to bring this chair down. It's like, well, then let's sit in the rolling spinning chair. Like, we don't want to because it rolls and spins. It's like, that's why I want to do it, because that sounds great. So I'm not sure that answers your question exactly, but I think there's, that component is huge for empowering them. The motor learning stuff, shout out to optimal theory, autonomy, like just simple choices. We don't need to get crazy because I'm simple thought process person. So it's like, do you want to use this color or this color? Like, just simple choices give them some type of control, because I can't imagine like having dizziness like significantly or consistently. And I can't imagine how out of control that must feel. So if you can give them any sense of some type of control, and again, the whole knowledge of results and timing things, and keeping track, like having the sheet that you track from the beginning, where did they start? Because this is the thing I don't want to forget to say, is that when we tell someone they're doing better, or it's like, whatever, Jay, if they still have dizziness, if they weren't like the way they were before, it's not, they haven't improved in their eyes. They haven't, and I'm generalizing, of course. So, but a lot of people, when I see them an outpatient and I know they're acute care therapist, and they're like, wow, they're a lot better. And they're like, I'm not any better, because they're not like they were before. So that's an important piece, because then when you write these things down and you show how, look at, you started at 0 meters per second when you did your gaits. You could not walk at all, remember? And now, yes, then you needed mod assist, and then you were by yourself and it was slow, but now you're increasing the speed, something more objective, because y'all, we don't go walk on a treadmill and just say, I don't care how fast I go or how long, or if I have an incline, I'm just gonna, we are motivated humans who want to see that we did something better and that we improved, and we need to be more explicit about it, I think, and highlight it more directly, like whiteboards, write it up there, like write it on. Just saying the words is different than visually seeing it.
I agree wholeheartedly with that. I think that what's really difficult for patients that are living with chronic dizziness or persistent dizziness is that they experience their symptoms day in, day out. We see them typically about once a week, and we can see the change and the small improvements, but having some reminders or some objective ways to show them, like, hey, your goal was to be able to get back in the woods and walk your dog and not feel dizzy. And guess what? Now you're walking around the neighborhood where you weren't even leaving your house before. Like, that's huge. That's amazing. And highlighting the small wins and celebrating with them, I think, is a great way to empower them, which is why clinicians who are watching, you have to make sure you have some patient-centered goals. Have your patient make goals for themselves and ask them what they want to get back to doing, and set the expectation that they may not be completely 100% better. They may not get back to where they were before. However, there is this opportunity to find a new normal and still achieve quality of life with these exercises, with this rehab. And I think that patients appreciate the realness of that, as well as incorporating things that mean something to them. So I think that's a really great component to patient empowerment that really needs to be taken into consideration.
And I think there's a lot of different ways. I know there's therapists all over doing, they just come up with the most amazing ideas ever. And it's just, I consider myself in a position where I can try and share those ideas. So I'm always grateful when I go somewhere and someone shares. I was like, I want to tell everybody. Can I tell everybody? Because that's what I do, is I try to tell everybody. And so, I think that people they look at it as just, oh, this is just something I've always done. And I'm like, are you joking? Because that's really cool and everyone should know that. And so I think just continuing to share and recognize that there's nothing simple about anything we do, especially given the settings you're in and the time frames and the pressure and the documentation and all those other things. It's easy to lose sight of and feel bad about what you can't do. So if you can stay focused on what you can and share those, especially within your team, like, try to get together as a team and share, like, this would be a dream. Okay. A dream of mine would be, at lunch once a month, because, you can't get crazy. Let's spend 15 minutes. I mean, after they listen to your podcast, okay? After they listen to your podcast together and come up, but they brainstorm, take a piece of equipment or a pillow from the clinic or from the hospital room or a sheet, and let's brainstorm 15 different things that we could do with this sheet. What do you do with it? What do you do with it? What do you do with it? Just to try to spark up a little bit of excitement of, oh yeah, I do know a ton of stuff. And, it's just, we need to find little ways to kind of support each other, I think.
Love that.
I love that. Hey guys, it's Abby here. Unclench your jaw, relax your shoulders, take a nice deep breath. Doesn't that feel better? Thank you so much for listening to Talk Dizzy to Me. One of our missions here at Balancing Act Rehab is to spread awareness about vestibular dysfunction, and the best way to do that is with your help. We'd be so grateful if you took a moment to subscribe, review, and share our show with someone you think would benefit from hearing our conversations. Let's get back to it. Talking and collaborating is something that social media has allowed all of us to do so well, even throughout COVID. And probably it took off more during COVID, the social media realm of things. We used to do something similar, not quite like that, but at my prior job at NYU, we would have almost like rounds where and I'm sure everywhere pretty much does, case studies, and you're sharing what you did to help this patient. But I love that idea. And I think that's one of the reasons we love this podcast, is because we get to hear from people that we don't normally see every day. We don't see how they treat. We don't see how they educate every day, but we get to now hear and then share with our audience their perspectives and their ideas. Now, one other way that we can get creative is by using technology. Can you talk to us about some of your favorite tech tools in keeping things exciting in exercise?
So I have a couple favorites, but I mean, and one is, here's the simplest one, is the Metro timer. And I don't really care which metronome app you use. And just the metronome itself isn't all that exciting, but I think that it helps you figure out a speed, whether it's a movement that you're trying to do from a supine to sit, or whether it's scooting so I can get multiple repetitions. And we know increasing speed helps increase aerobic intensity. Like, that's one of our lowest hanging fruit. And so then once I kind of figure out a speed, I want to do something, can you figure out the genre of music? And there's just it's so easy to do a little search on a song at 50 beats per minute from the 80s. And then you try to listen to a couple. You can't do this with everybody. Or, hello, you have a student, and when you take students, you need to teach them stuff. And this is a really good thing for them to have to identify, because then when you practice it every time, you're going to get more repetitions because the music's motivating. Once you start playing and not just random music, it's it's structured, but you're opening up many areas in the brain, and you're more likely to get that speed. Whether it's cadence, we always want them to walk faster, and you're utilizing cadence with a song, but be more specific. You'll start to find some key songs that work really well. And Mustang Sally, that's a good one. And with a good, from a timing perspective, to get the hard beat, and then a lot of people know that song. So I think the timer just helps you get, being able to figure out the speed to then be able to search a little further to make that more interesting. And on that note is the Clock Yourself app. Just, boy, those Australians got it going on. And it was just one of those apps that I know a lot of people use it, but you can use it in any setting. You can use it in any position. You can use it with any patient diagnosis. So I think that from that standpoint, it's just, just even the 4-block color, where it's red, yellow, whatever the colors are. I should practice more, but and make it simple. Or they could be sitting and doing the clock and moving in those directions, and then close their eyes, so they're increasing body awareness, and then increase the speed. And then there's so many levels. Then it's something they could do at home. So when you're looking at trying to facilitate reactive balance or increasing stepping, and you want to do it somewhere safe where they're holding on, you could get those pieces to be able to do that. So I think that that's one of my favorites. And I think when we talk about aerobic intensity and trying to increase people's aerobic intensity, but make it, according to what they're able to do, then I would go with the Smart WOD timer. Do you guys use that one? Because I don't know if I'm saying it right. Do you know if I'm saying it right? SMARTWOD, Smart.
Yes. Yeah. So WOD, I think, stands for workout of the day.
Yes.
Oh,
Smart WOD. Yes.
See, so I use it. I don't even know what it stands for, but I like it because it has, a lot of people like to use EMOMs, like every minute on the minute. For my neuropopulation, I prefer AMRAPs. So as many reps as possible. They pick the amount of time, so 3 or 4 minutes, because I want more repetitions, and sometimes they can't get very many in a minute. So, I don't really care. And then Tabata is just trying to get the high intensity where you're like patients with MS. There's really great research on high intensity interval training. So as fast as they can walk for 30 seconds and then do a dance break for 1.5 minutes. Or it could be longer, whatever they need, and then go as fast as you can, so you have, but they can see it and they can pick the numbers. And, so I would say those 3 are my favorite.
What I love about all those apps, though, kind of getting on the documentation side of things, is that is objective information that you can use in all of your documentation and show from visit to visit. And then you can also use that, again, to kind of go back to patient empowerment, is showing them like, hey, remember when we did this exercise and you're only able to get so many reps in this time? Look at where you are now. You've doubled that. You've tripled that. Look how amazing this looks. Like, it's such a great way to not only document and show objective findings, which in the vestibular realm of things can be very difficult. Dizzy is a very subjective thing. So how do we show progress? How do we back up what we're doing for insurance companies who want to cut our visits? Like, I think that using these apps are just a great way, 1, to get the patient to buy in and have fun playing these games, but 2, also showing the objective measurements behind utilizing those apps and then putting them in our documentation. I think it's a really great aspect in both patient facing and also keeping all of the insurance companies happy.
That's beautifully said. I think that's a really good point. Moving forward, I've been saying this for the last couple of years, but it's on my list of things to do, is continue to work on how to integrate some of the ideas or different things into documentation. Because the one thing I get a lot of times from like my MedBridge course is like, oh, Jay, I really liked your ideas, but I'm not going to do them. And I'm like, okay, like I can read your email. Like why, what's up with that? And I get, they're like, well, cause I like to try something 10 feet. Now try it a different way. Head turns. Now try it fast. Now try it pulling a suitcase. Now try it with resistance around the waist. Now try it with you pushing me. So, and I'm trying to compare and contrast how did they respond to those different types of stimulation? So I know, okay, they did better when I was resisting around the waist. Okay, that means more glute activation versus trunk with the arms or whatever. They didn't respond well to vertical head turns versus horizontal head turns, or eyes closed was a big bad bust or whatever. So I'm like saying, if you can do smart, short distances, but a variety of different ways, like that's going to give you a lot of information. And they're like, but I'm not documenting that. And I was like, well, don't document all that. Like, document you ambulated 10 feet times 10 with various balance challenges. Bam. Then pick the one thing that you thought what had the biggest impact and highlight that for either the next person taking over for you, or just for me to be able to think about why did they have such a hard time with horizontal head turns? Like, what was up with that? And so then I can pass that along to OT. And so OT can incorporate doing that in their, and do more tracking when they're doing the kitchen activity or whatever. I'm making stuff up here, but, I just think that we can do something like that and make the documentation appropriate. And it's going to vary based off your setting, but also based off what is our goal. And we need to try more things, and you can't be documenting all of that. And that's not the intent. The intent was to provide various balance challenges.
Amen.
Drop the mic.
Yeah, big drop. With that being said, definitely neuro, but also somewhat more vestibular specific. Can we get a little bit into reactive versus anticipatory balance and kind of your go-to exercises when it comes to balance specifically? Let's talk about dynamic balance, like in standing, more functional exercises.
Well, oh boy, Abby, that's tough. So I mean, just like, let me think. From anticipatory, because reactive is my jam. I really love reactive because of the results I've seen with trying to push towards reactive. The challenge, so anticipatory is I know it's coming. I'm going to lift up this weight, but I know what the weight is and I'm anticipating it. And so, I mean, you go up and you start pushing on someone, perturbations. That's what I learned was balance challenge. That's anticipatory, because once they know you're going to push them, they just lock down and you're like, oh, they're really good. Well, once you put a towel in their hand and you start pulling it randomly like a bad dog, that's my favorite, bad dog, and you're going in all different directions, they don't know where you're going to go. And all of a sudden they fall apart. That's reactive. Now, the challenge is, and the reason I'm hedging a bit on that great question, is that once I think is a good idea, they figure it out. And once they figure it out, it's now anticipatory. And I'm like, thanks a lot. Now I got to think of a new idea. So when they're at home, I would just go with speed. Like you have them at a counter, the chair's behind them, or they're in a corner with a counter in front and a chair on the side, the back of a chair on the side, like cage them in wherever they need to be, or standing in front of the couch so that if they lose their balance, they just sit down on the couch. Like that's cool. And do fast stepping out and stepping in. And so that's where the Clock Yourself app, I think, can come in handy, is because they need to be able to step quickly if they lose their balance. And so, and I've seen it, consistently in my research, how well they can acclimate to that if they're challenged, right? But we worry about safety. So find a place to cage them, just focus on those pieces. If you can add resistance and they can do it. But if they lose their balance backwards, but we don't want them to do that. I understand. So corner them and do quick stepping in all directions, quick motions of hands, adding those pieces together. I guess just off the top of my head, from a low hanging fruit and home is important. Then with us, the thing is with us, like, I don't want to do standing. Like I want to go to the highest possible level challenge I can do when they're with me, to try to anticipate, because I have no idea what's going to happen when they get home. So they go home and they're walking pretty well and they're turning okay, because that's risky. But then they have to go to the bathroom, so they're thinking about that. And then the doorbell rings and they turn to answer. They don't even think about it. And that's when they fall over. So I need to try to take my balance challenges up 3 levels higher. Like if you're just standing there next to them as they're walking, I'm bored now. And if I'm bored, then they're not on a reactive balance. And I have to tell them that I'm going to keep pushing you. And if you're like, well, I'm afraid they won't be safe, you put that gate belt on, you get the wall on one side, you cage them, and you start to, if you hear yourself say that, well, I don't want them to lose, they've got to lose their balance. I did not say fall. Don't say I did. But they've got to lose their balance, and against a wall, if that's what you feel, in front of the mat, but pushing them enough to where then you let them go down and sit down. Let them go down and sit down when they're with you. Because that's what wakes up the cerebellum to say, oh, Nellie, like what just happened? If we keep fixing them or making them look too perfect, we're not going to get what we want. So we still have work to do. If you have a harness, you go, yay. But most people don't. And so you can work on trying to get a harness, but don't feel like you can't do anything. You just do it in part task. Just do it where you can, but go faster and add perturbations and let them err safely, plop, but let them plop. What's wrong with plopping? Like plop has gotten a bad rap. When I grew up, when I was in PTs, don't let them plop. You got to slowly lower them. Like, let them plop. nothing happened except the cerebellum woke up a bit. So to know what to do. So I think that, I am going to tend to err conservatively at home, making sure, like, if they don't have glute med strength, they're going to fall when they turn. They don't have the pelvic stability. So low hanging fruit at home is impairment based sometimes. And people will argue whether that's a good thing or not. But that's just kind of my go-to. If that's something, I'm not going to do that. That's like boring. Like, whoa, boring. That's something I could give them something strong to do. But then when they're with me, it's like as high as we can go. And when I'm on Zoom, I'm like, okay, you don't know me. And are you going to be okay if you're tired afterwards? Like, are you going to have issues with that? And I had one guy tell me, I've seen 6 different therapists and I've never once been tired after therapy. And I was like, sounds like fun.
Challenge accepted.
He lasted 45 minutes. And, and I wasn't doing anything like overly exciting. It was just, I was trying to target and go all in and go higher. And instead of just waiting for him to stand up, I was like, you touch the bottom, and once your bottom hits that chair, you stand right back up, quick like a bunny. And he's like, I can't do that. And I said, could we try first? Like, just, go down, touch, and quick up like a bunny. And then the OT was there, and who asked me to come in. And I said, help him, make it happen. And once he got it, like, I got a smile out of him. And after 45 minutes, he's like, I'm tapped. And I was like, I'm sorry, I didn't hear you. People get used to me. You guys don't know me, but
it's amazing. I think a really great message you're giving is something that I also like. I've been using now for a little bit in my practice, maybe not 10 years ago when I first got out of school, but this is what I've noticed that works with my patients. They're coming into the clinic to do something that they can't do on their own. And when they're working with us, we have to challenge them. We have to make things super difficult in here for them so that when they go home and they have to step up on a curb, or they have to get in their front door, they have to make that turn around the corner, it feels easier than the stuff I'm making them do here. And I think it's really important that we remind patients, our goal is to try to trip you. I want that fall reaction. I want you to feel nervous about falling and have a better anticipatory reaction to that fall so that we can combat that. You don't freeze and fall over next time. When you explain that, there's a lot of times that there's a light bulb moment that kind of goes off for the patient. And I think for clinicians, they need that light bulb moment too. You got to be confident in the skills that you learn in PT school, on clinicals, and while you've been treating patients, that you're not going to let your patient fall. Because one, we don't want the extra documentation for incident reports with that. But you have to be confident that patient's not going to want to fall either. They're going to try to prevent that fall, and they're going to learn from that. So challenging them, putting them through the tough stuff, although it's, it requires a little bit extra work and a little bit of a higher nerves for us, I think it's so much more important for carryover for the patient and seeing those results that we're looking for. So I think that's really great advice.
And just 2 quick things, because that was just so brilliantly said. But one is that I think that they like it. They love the fact that you expect them to do really well if I challenge you. That means you believe in me. So when you're talking about empowering, I mean, it's all in presentation, but seriously, I really do. I wouldn't be doing this if I didn't think that we could get you to here. But the other thing is I think as therapists, hear yourself. If you are saying that's not safe, I can't, if right away you're listening to this podcast, you're like, I can't do any of those things because it's not safe for my patient. So let's just start. What are you doing? Okay, could we just be nice to yourself? Can I take that little thing and make it and do it faster? Could I add, where else could I do it in the room? Why don't you just brainstorm with everybody but listen to where you feel like you're limited and go all in on that, because do it as a part task. Don't do it as a whole. It's not 0 to 60. Those aren't our 2 options. There's 59 other numbers in the middle. Like, so let's be nice and just start working and go a little bit further and go, wow, I didn't think he could do that. And I can't tell you, and more often than not, I'm like, I'm going to try this and it's kind of crazy and it's not going to work. And then they did it. Like I'm going to guard here and I'm going to do this and I'm going to guard here and I'm waiting. And then they just do it. And I'm like, whatever. Okay. That was supposed to be hard. And I'm like, crud, now I got to think of something harder because that's not what I thought was going to happen. So I underestimate them, not on purpose, but it just continually happens. It's amazing. It's fun, but be nice. Be nice.
Yeah. The challenging part, the word challenge rings so true to our patient to our patients with vestibular dysfunction, because that is really what our therapy is all about. And what you said, 0 to 60, I actually start every single evaluation. At some point in the evaluation, I say that we're not going 0 to 100. We're going 0 to 10 to 20, maybe back to 15, and then to 20 again, and then 25.
Oh,
You know,
nice.
they need to understand that this is a progression. There might be some regression sometimes, but the overall trend is up. JJ, it has been such a pleasure to have you. And we don't know you very well, but I can tell you one thing, we like you.
Thank you. You guys are very sweet to have me. I really do appreciate you even thinking of me. And I find it an honor to be on your podcast. So I appreciate all your hard work too. Y'all, you've been doing this for so long. It's just so impressive. And you're helping so many therapists. So thank you for your dedication.
Absolutely. And audience, you can find JJ. JJ, tell them all where they can find you.
I feel like too many places. Well, you can go to Instagram and find me most places. And Neuro Collaborative, I do some mentoring with the NeuroSpark crew, the Claire and Aaron. They're wonderful ladies to work with. So if you search me, unfortunately, you can Google me and probably find me wherever you want.
Don't forget MedBridge. Those MedBridge courses
Yeah.
are awesome. And we'll link everything in the show notes so people will be able to find all of the great content. Thank you. Thank you. Thank you. This was such an amazing episode, and we feel really honored to have you on. Thank you so much.
Thanks, Danny and Abby. Appreciate it.
This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.